about 8 years. I'm one of the nurse practitioners and my co-moderator.
Delighted to be here. My name's Jerry Eastep. I'm an advanced heart failure specialist. Currently in Cleveland Clinic, Florida, where I have the privilege of overseeing our cardiology efforts there in our 5-hospital system. Was at Houston Methodist for about 10, 11 years prior to transitioning to Cleveland Clinic. So super excited about being back at the Shock Symposium and particularly excited about this particular session.
Thank you so much for coming again. We have our panelists here. We have Jordan Garcia from UT Health. He's one of our physician assistants. We have Emily Ingebretson. Did I say that right? Yeah. She's from Sharp Memorial in San Diego. She used to work with us. And then we have Tanya Page from Memorial Hermann, and she is the Director of Advanced Practice Providers there. So we're going to go ahead and get started. We're going to have the cardiogenic shock survivor case presentation by Jordan.
It's the green button. Hi, my name is Jordan. I'm a physician assistant with UT Health here at Center for Advanced Heart Failure at Hermann in the Medical Center. So the case today is about a patient that I took care of in the IMU, both pre and post intervention for his cardiogenic shock, and then got an opportunity to take care of him in the LVAD clinic as well. So the initial presentation, he was a 37-year-old male with a history of COVID-19 infection who was diagnosed with heart failure about a month prior to presenting to an outside hospital where he came in with symptoms of chest heaviness. So his vitals on the initial presentation is blood pressure is a little bit low with systolic in the 90s, heart rate of 98. He was on room air, normal respirations. He had had a left heart cath at the time of heart failure diagnosis a month prior, which didn't have any coronary disease. Labs are notable for a high sensitivity troponin around 1300, which then plateaued. ECG was negative for any ischemic changes. BNP was elevated around 1000. They did get a CTAP protocol, which is negative, chest x-ray with a moderately enlarged heart size with no other remarkable findings. And they did repeat an ultrasound, which showed a worsening of his EF from prior and worsening of his mitral regurgitation. This is his chest x-ray. So essentially at the outside hospital, the symptoms resolved pretty quickly, but they had trouble initiating guideline-directed medical therapy because of his blood pressure. So the decision was made to transfer to our center for evaluation of advanced heart failure therapies. So on arrival to our hospital, his vitals are essentially about the same. Once again, systolic was a little bit low with blood pressure in the 90s, but otherwise pretty unremarkable. Physical exam, he was alert, awake, he wasn't in any distress, no scleral icterus. He did have mild elevation in his JVP, and he did have an S3 gallop, although it doesn't say it here, but he did have an S3. Lungs were clear, auscultation, no ascites, abdomen wasn't distended, and I think, importantly, he didn't have any edema, and his extremities were warm, definitely not cold by any means. His lab work showed essentially normal end organ function, normal renal function, normal liver function. His lactate was in normal limits. CBC, as you can see, was overall pretty unremarkable. He did have a positive UDS for cannabis. COVID-19 was negative, and his thyroid function within normal limits. His other cardiac biomarkers were essentially the same as at the outside hospital. And he did mention that he had traveled recently, I believe, to Mexico, so we screened him for Chagas disease, which was negative. So we did get repeat imaging in the form of echo and cardiac MRI. The ultrasound showed a depressed EF around 15 to 20%. Severe mitral regurgitation, dilation of his left atrium, mild reduction in the systolic function of his RV. And then it's not up here, but his LV was about 7.8 centimeters, so it was quite dilated. So following up, we did kind of a non-ischemic evaluation in the form of cardiac MRI, which essentially the main differential based on the cardiac MRI was either a genetic cardiomyopathy or prior myocarditis, which was notable given his previous history of COVID-19 infection. And so for his hospital course, his main symptoms early on were mild shortness of breath, some nausea and constipation. Vitals at this time, systolic remained in the 90s, but intermittently he would be tachycardic into the 110s, although sinus. He was on an SGLT2 inhibitor as an outpatient, which continued, but we stopped his beta blocker due to concerns for possible low flow state and because of his blood pressure. And then he was given spot diuresis with IV push Bumex for mild volume overload. He didn't have any arrhythmias at this time, so no use of inotropic support, and his end organ function remained normal this whole time. While this is going on, we're also beginning the process for evaluation for advanced heart failure therapies concurrently. So the next part of that process was getting invasive hemodynamics with the right heart cath. So you can see his hemodynamics here. RA pressure was essentially pretty close to normal. He did have moderate to severe pulmonary hypertension, and notably, he did have a quite elevated wedge pressure and a pretty depressed cardiac output and index, given his presentation. So pretty much shortly right after this right heart cath, he got more hypotensive with systolic in the 70s, more symptomatic with nausea and shortness of breath. So at this time, the decision was made to place a balloon pump and transfer him to the ICU for further care for cardiogenic shock. So I'd like to take a break here to kind of talk about heart failure and shock assessment, especially in the IMU, where we don't have the same resources as our ICU colleagues, such as PA catheters. And so I think as we talked about a lot today, our physical exam becomes even more important. I put up this diagram because it's something that we're taught pretty early on when assessing for shock. And essentially the way it works is based on signs of congestion or perfusion or lack thereof. Your patient fits into one of these profiles, and it's supposedly supposed to tell you something about how they're supposed to be treated. But if we do an exercise and apply this patient to this diagram, he didn't have cold extremities, no prerenal azotemia, he wasn't oliguric, not in kidney failure, he was not altered. Can't see it up there, but he had good response to the diuretics, and he was never hyponatremic. And he did have some signs of congestion. He did have the elevated JVP, but no. He did have a S3 gallop, so sorry, that's a mistake. But no major lower extremity edema, no P and D, no major weight gain or B lines on his chest X-ray at least. So I think the point I'm trying to make here is that not everybody is going to fit nice and perfect into one of these profiles, and especially when you're evaluating patients in the IMU, you have to be cognizant that they can rapidly fluctuate between these different profiles. I think some of the red flags for this case that let us know this patient probably wasn't doing as well as maybe you could have assumed was that the hypotension, the tachycardia, of course, and which worsened anytime they try to start a beta blocker, inability to tolerate GDMT, and then his young age. It's purely anecdotal, but anyone who is a young age with a new diagnosis of heart failure and kind of mild nausea symptoms always kind of raises a big red flag for me. So for the rest of hospital course, he was presented to MRB pretty quickly and approved for LVAD destination therapy because of the THC use. And so he was implanted with the LVAD about 3 days after that and placed on milrinone and Bumix strips right afterward. He spent a little bit over a week in the ICU just kind of being optimized, and then was finally transferred to us on milrinone drip as well as IV push Bumex and hydralazine for afterload reduction. So we kind of worked in a stepwise fashion to wean these things off and kind of get him ready for discharge. So the milrinone was weaned off the next day, and then the next day we stopped his diuresis and increased his LVAD speed to augment his cardiac output. At that point we got a repeat ultrasound which showed good unloading of his LV, no major valvular abnormalities or suction, and monitored him for another 24 hours after that, and he was discharged. He didn't require any inpatient rehab or anything because he was previously a really young, healthy guy. So currently we're following very closely in our LVAD clinic. He's participating in cardiac rehab and doing pretty well, regaining his quality of life. We are starting medications in the hopes of possible recovery, although given his LV size and the fact that the MRI already showed fibrosis, I'm not completely sure if that's going to happen. We did get the results of his biopsy, which, like I said, showed fibrosis, but overall pretty non-specific or non-diagnostic. And then interesting, he did get genetic testing, which had a muscular dystrophy variant of uncertain significance. So how much that playing a role, not entirely clear at this point. So for the takeaways, I included the SCI shock classification, the definition of cardiogenic shock. Like I said on the previous page, not to say that they're not always going to fit very nicely in one of these profiles. I think you could say he was probably around stage B, but you can see that he rapidly progressed to stage C with not a ton of warning signs. So I think especially in the IMU, it's important to remember that these patients, it's like on a clinical spectrum for cardiogenic shock. And especially for us, we have a really big opportunity and responsibility to identify these patients early and prevent future complications such as renal failure or liver failure, which can impact their ability to undergo advanced therapies down the line. And that's it. Thank you.
So, Jordan, excellent presentation. A lot to talk about, and we want this to be a discussion. And so we have a number of questions, but most important, it's questions from you. And let's proceed over here to the left. State your name, where you're from, and your comment or question.
Hi, Jordan. I'm Sandra Hyder. I'm one of the nurse practitioners in the CVICU at Hermann TMC. We're hiring. Anyway, I wanted to ask, being that you're in the IMU, we split our ICU IMU as well, and length of stay is always a big topic of discussion. So from your standpoint, how can we help with length of stay, specifically on these patients who are so sick and stay for an exorbitant amount of time before we can correct them?
PT and OT early, I heard that mentioned earlier, and I think we, I mean, obviously everyone's focused on saving their life and optimizing them from a heart failure standpoint, and we kind of forget, you know, a week before discharge, crap, they don't have anyone evaluating them. So, I mean, as soon as we know that the person's gonna be there for an extended period of time, getting PT, OT on board, getting case management involved, and kind of staying on top of them to make sure that, hey, we need to have a plan for this patient. I mean, as you know, there's so many times where we do a lot of work to save a patient's life, and then we get to discharge, and you know, we don't maybe have the best plan for discharge. So just getting everyone involved early, I think.
Thank you.
Excellent. I'll add that as soon as you identify advanced heart failure or end stage, where the likelihood for recovery with medicines is low, like in this gentleman, the quicker the decision on next step therapy, LVAD transplant optimization minimizes your overall length of stay, which has a number of implications, including cost, with the benchmark post-LVAD being between around 21 days. And so your time frame looked pretty good.
Yeah, that was,
as it relates to decision-making, supported, optimized in the absence of end organ dysfunction. So certainly a highlight on the presentation. Let's proceed with another question over here on the left.
Okay, yeah. Hey, I'm Marie. I'm from UAB in Birmingham, Alabama. And along the same lines, I think one reason this patient got out so quickly is because you intervened quickly. When we see with our patients, this guy would have been like, I'm not that sick. I want to go home. I don't want an LVAD. That's really scary. So how did you push past that with his young age and low intermax status? Because we see, they say that, they go home, then they get sicker, they're on inotrope, they finally come back to us as an intermax 1 when you had the long length of stay post-implant. So how'd you get him?
Yeah, he had that exact same problem. He was a really previously young, fit, healthy guy, you know, so he had the exact same question. I think we actually showed him his ultrasound. You know, we showed him, hey, this is what a normal ultrasound should look like. And, you know, like I said, his LV was quite dilated. And someone who's not in the medical field can see that and say, oh, my heart does not look how it's supposed to. So we actually did show him, and that kind of helped, I guess, not convince him, but educate him that, hey, you're sicker than you realize, basically.
Okay, yeah, that's a good idea.
So great question. And I think it's a nice opportunity to get panel discussion. And so Emily and or Tanya, what's being used at your facility to not only inform the patient-related projected benefits, that's informed consent, but shared decision-making so that the patient has a full breadth of understanding of trajectory, medical therapy, watchful waiting, LVAD, one could even throw in transplant. So what's the approach at your institution?
I think it just takes a lot of re-education with the patient, especially when they're that age and feel invincible. It's hard for them to understand their prognosis, even if maybe this guy goes home and has recovery and maybe you can explant him, you know. It's just kind of lays on the shoulders of the staff who are taking care of the patient to make sure that they're well educated on what's going on with him.
One thing I'll add to that is that the entire team, I think, has to be on the same page as well, because when there are different providers, different care team messages going to the patient, I think they get confused, and I don't think that they're getting the same message. So this person told me I could get transplant, but this person is telling me I can't. This person is telling me that I'm an LVAD candidate, or this person is telling me I can go for recovery. So I think the care team itself, and this includes case management, social work, nurses, advanced practice providers, physicians, surgeons, everybody that's involved in taking care of this patient to have the same message for the patient.
I think that's a critical point, and you don't wait for a selection committee meeting to deliver a message on prognosis and potential next step. You certainly start the evaluation and highlight the team's going to make a decision, but the less inconsistencies in his poor prognosis, right, acute on chronic heart failure, complicated by shock, and you can reference SCI, you can reference intermax profiles, he's likely not to do well, right, without a next step therapy. The more consistent the team is, leveraging huddling, right? How many times is your team huddled together, surgeons, specialists, case management, other care providers, the more often, the better to create that team similar messaging. Any other comments from the panel? So thank you for that excellent question. We have about 1 minute and 30 seconds, and I didn't want to steer off the nice lady that was standing up to ask the question. But I'll go ahead and leverage this time to ask about the hemodynamic profile. We have a nice session about hemodynamic profiling. The one thing I didn't see on the report was systemic vascular resistance. In the context of a remodeled heart, an afterload mismatch with high SVR, when you're significantly above 1,200 dynes per second per centimeter to the negative fifth, you really can leverage medical therapy to prove that you can't increase output without compromising blood pressure and preserving that trajectory of maybe bridge to medical therapy. So it's still an art using the SWAN tailored therapy to guide decision making. I think the jury was out.
Yeah.
No forms about decision making, but one would want to see the mean blood pressure SVR as part of that comprehensive report to understand that. Even more worrisome when SVR is in the normal range, let alone low, in the context of inflammatory response of heart failure and progressive shock. So one consideration.
Yeah.
Excellent. So thank you.
Thank you.